welcome everybody to Dental Hour then. This is a program, as you all know. I started last year, immediately when COVID started. Purpose of it is for us to do greater dentistry with all different variety of topics. Also, most important that I have enjoyed inspiring each other, supporting and staying connected. And tonight's presentation is going to be a special one. I want to welcome Dr. Koslowski to our Dental Hour. Thanks, Ron, for giving me this pleasure for tonight's presentation. So let me give you a little bit of who Ron or Dr. Koslowski is, which is very important. He's local. He's from Los Angeles. He went to one of the best dental schools, UCLA School of Dentistry. And then he specialized his training in advanced prosthodontics, and he went through UCLA PROS program and the Wadsworth VA Medical Center. Then he decided to do a fellowship in maxillofacial prosthodontics at the Memorial Sloan Kettering Cancer Center. And this is something he likes, and he has focused, and he has published a book which is titled "Take Back the Smile That Cancer Stole: The Cancer Survivor's Guide to Better Dental Health." He has been board certified since 2000 and was named Fellow of American College of Prosthodontics. He, as a lecturer at UCLA, he's a lecturer at UCLA Dental School, and has participated in the clinical training of dental students and specialty residents for over 15 years. This is what you and I have a lot in common, you know, the constant education. He, we all know, he maintains a private practice in Encino, a very successful one, and specializing in prosthodontics, maxillofacial prosthodontics, and dental oncology in our local area, Encino, I should say wider Los Angeles. So with no further delay, it's an honor to have you part of tonight's presentation. So I'll let you take over, Ron, and thanks for doing this for us.
Okay, good job, Nick.
Thank you very much, Alfred. Very nice introduction. I was listening to that and thinking, wow, this guy sounds like he's pretty good. I'd like to meet him. But anyway, it was very, very kind introduction, and it's really
my pleasure. I've enjoyed working closely with you. So
yeah, and I've always had the pleasure of working with you, Alfred, for many years, and we've learned together. We're still students through our SPEAR study group, and we have that in common, is that we have this never-ending thirst for knowledge, and we want to continually get better at what we do, and we both understand that that's a never-ending process. So thank you again. What I'd like to talk about tonight are two topics. One is one more of a clinical topic, and the other a little bit of I don't want to say practice management so much as maybe even kind of life management, time management, which time is so important to all of us, and making the most use of it. So we'll talk a little bit about some of what I've learned from one of my business mentors a little bit later. So why don't we start with Jennifer was kind enough to help me out with getting the Zoom screen sharing. So I'm going to see if I can actually make this happen. Let's see. Bear with me a moment. Okay, so I'm going to share my screen, and hopefully we will see the first slide here.
Oh, it worked. Perfect.
It worked. Okay, let me go into presentation mode. There we go. Okay. All right, are we seeing that okay?
Absolutely.
Good. Okay. Now what I want to do is see if I can get. Okay. All right. So I'm choosing a kind of a back to basics topic for prosthodontics. This is going to be a little bit of old school prosthodontics, but using that as the basis for our implant reconstructions. So especially in our study groups, Alfred knows extremely well that if we're planning a implant restoration, especially a full arch restoration, whether it's going to be a full arch of crown and bridge on implants, or if it's going to be a hybrid all-on-4 type of prosthesis, or whether it's going to be an overdenture supported by implants. The actual classic denture making techniques are so important for having proper planning. So when we discuss dentures, a lot of patients have their issues with a removable prosthesis, and one of the main problems is that patients get upset when they don't fit. So this I actually found. Let's get a closer look at this. I went to a dental meeting, a study club meeting a few years ago, and saw something strange bolted to a tree trunk. And it seems that someone was so unhappy with their removable partial denture that they decided to nail it to a tree, like Martin Luther nailing his manifesto to the church door. But so this is a common experience that we've all had with our patients who wear removable prosthetics. The problems, some of the problems that I come up against in my practice are, patients have a high aesthetic and functional expectations. They may have various degrees of success in using dentures, and implants can be an excellent solution, but unfortunately, what we've seen is that sometimes they get placed without a restorative treatment plan. Some patients can use ill-fitting dentures successfully, and others can't use the best fitting dentures. So a lot of patient factors. So getting from point A to point B, so the modality of treatment we use, the chances of success will depend a lot on patient expectations, their anatomic limitations, and having a carefully developed and well presented treatment plan, all essential. So we'll talk about the benefits of well-constructed dentures, whether they're the end of treatment or the beginning of treatment. We'll talk a little bit about diagnosis and treatment planning, the sequence of denture making and making of implant stents. So I'm going to inject a little bit of controversy because some of the most popular treatment right now is to go straight from a failing dentition to an implant supported prosthesis. And my feeling has been, and it still is to an extent, that some patients are better off wearing dentures and learning what that's all about before going into an implant treatment. So everyone's talking about immediate loading, immediate placement, and can be a fabulous technique, for the right patients. Sometimes for the right patients, though, learning what experiencing a denture is all about can be an important step in the treatment. Well-constructed dentures are cost-effective. They can be a phase in treatment. Like I said, they can experience the limitations of dentures and maybe appreciate the implant treatment plan that they were thinking about a little bit more, and helps us to establish our aesthetic and functional goals for implant treatment. So if a patient is unhappy, or if they complain that the dentures don't fit, it might be easier for them to understand that this is due to their own anatomical or adaptability limitations. So the denture as a diagnostic tool will really help us to see if the patient can adapt to a removable prosthesis, and whether or not they're going to need a denture flange. So we're going to go through the diagnosis and treatment planning sequence for implants, and for dentures are almost the same sequence. We want to know about their general health. Is there any oral disease? Is there any systemic disease that could affect the chances of success? Psychological factors. So back in school, we learned about the house classification of denture patients. So there are 4 categories. The philosophical patient, which is considered the ideal. There's the exacting patient that as specialists we see a lot of in our practice. The indifferent, and which is a very difficult type of personality to manage, and then what was called the hysterical patient. So other things: depression, chemical dependency, OCD, those can all affect the prognosis. So you get a patient who comes in with their dentures full of this particular patient came in with dentures very carefully lined with little pieces of Kleenex to get it fitting just right. So that's one of those red flags. So we look at the mucosa. Attach. We want to see if there's attached tissue, which, as we know, is really going to increase, better prognosis for both dentures and for implants. Look at the quality of bone. We can go all the way back to 1985. The classic Lacombe and Zarb classification, where we look at the quantity of bone, A for the most bone and E for the least bone, and then the quality of the bone from 1 to 4, where 1 would be mainly a cortical bone, and which and 4 primarily softer cancellous bone. Look at the maxillomandibular relationships. So if a patient has a prognathic mandible, we have to be careful, because lower implants can destabilize an upper denture. With a retrognathic mandible, the patient tends to posture forward. So we want to be careful, to give them the room to go in that position, and not try to make it a perfect locked-in bite. the we also look at the the resorption of the ridges, and we look at the occlusion. So the opposing occlusion we look at to the arch we're working on. If they're natural teeth or implants in an opposing arch, those are going to generate much greater force than a denture. Often we'll take the patients, if they're wearing existing dentures, we can remount those on the articulator and take a look at our inner arch space, which is so important for planning an implant restoration. We can look at, we can confirm our assumptions about problems with their occlusion, and we can show the patient how their dentures are functioning, and and it can be a very dramatic demonstration to show a patient, show them their own dentures on the articulator, and showing them exactly what we're observing. So the rules of 10 have been written about, guidelines for successful treatment of mandibular edentulosum using dental implants. That goes back. We look at oral hygiene. So most patients have lost their teeth due to poor hygiene. What we often find is that unless we can really inspire the patient to get the religion of oral hygiene, they may not take great care of their implants, or there may be manual dexterity problems, difficulty there. So super important to have adequate hygiene follow-up. So we look at all the factors. A lot of factors can affect the denture prognosis in the maxilla, ridge resorption, the shape of the arch, what kind of vestibule they have, and of course we talked about the jaw relationship and expectations, and similar in the mandible, the resorption, the vestibules. So all of these things we have to evaluate whatever our restorative treatment plan is going to be. In the mandible, also the tongue, extremely important. So they might patients often have if they've been edentulous for a while, the tongue tends to expand because the tongue is very strong muscle, and when there are no natural teeth to chew with, the tongue can expand to fill the space. It also works harder, so that large, strong tongue can really wreak havoc with denture stability. Just to review the sequence we go through when we make complete dentures. I pretty much make my dentures very, very similar to the way I made them in dental school, and I've found that some of the, at least in my hands, a lot of the old school materials and techniques still work great. So for the preliminary impression, our objective is to record all the areas to be covered by the denture and the adjacent landmarks. I still use alginate for that. Design custom impression trays. This example shows a selective pressure technique where we've blocked out some of the non-primary denture areas. So we want to have lighter pressure in the vestibule. We want to have a little extra pressure on the primary bearing areas. Final impressions, again, old school stuff, good old border molding with impression compound, the old stinky polysulfide, and or zinc oxide eugenol paste. Still my favorite materials for denture making. Making our jaw relation records. So we come back with our occlusion rims. We evaluate the physiologic rest position, the occlusal vertical dimension. We make our FACEBO records, our centrifugation records, protrusive records. I typically wait until I have some teeth set to get that a little more accurate. So for the aesthetic try-in, now we go all the way back to the techniques we look at today when we're making anterior crown and bridge, when we're making veneers, we're making implant supported crown and bridge. It all goes back to this, and it's kind of a shame that they're not having dental students set their own denture teeth anymore, because this is where you really learn about aesthetics and how to make things look beautiful. So back in the 1950s, Frush and Fisher wrote about the sex, personality, and age factors in setting denture teeth, and also looking at the phonetics, the F sounds, V sounds, and S sounds, all affected by proper placement of the teeth. So we deliver the dentures. This is still what I do. This is what I just did this afternoon. We use the pressure indicating paste, check the borders with disclosing wax, remount, and equilibrate. This wasn't from dental school. This was from this afternoon. Making a couple of sets of jaw relation records, putting the dentures back on the articulator, and checking against a second record to make sure that we had a repeatable relation, and then go ahead and adjust in. My laboratory technician did such a beautiful job of processing with minimal error and correcting for any processing errors in the lab that I did not have to do a lot. So there's an adjustment and adaptation period of usually, if it's an immediate denture, I usually give at least 3 months before, if the patient isn't sure that they're interested in implants, then we let them use the dentures for a few months, let the bone fill occur, and then discuss definitive treatment if they're not satisfied with conventional dentures.
I have a question for you, Ron.
Sure.
If you were making an upper and lower denture and the patient absolutely was not interested in having implants done, would you have put the second molar on there?
If they were not, let me make sure I understand. So if we know they're not interested in
going to have implants, they were just going to go with a full upper and lower denture.
Yes.
You would put it on. And do you leave it off only because when you transition to a full upper and lower to implant supported, we shorten the length of the arch?
Yeah. So typically, if our final restoration is going to be like an all-on-4 type of prosthesis, then yeah, we typically, it depends on the anterior posterior spread of the implants, of course. But I still, whether or not I place a second molar on the dentures has more to do with the arch length, how much space I have before approaching the ascending ramus, to the retromolar pad.
Right.
So, but I'll generally try to get second molars in a complete denture if there's room.
The only reason I ask that is because in the cases that I've done on all-on-4s, people are transitioning out of a full denture, and then you give them your all-on-4, and they go, hey, I paid a lot more money for this, but I don't have as many teeth on my denture. And you're like,
Hey.
and then you try to explain AP spread to them, and that goes over really well.
Yeah, I like to have those discussions ahead of time.
Yes.
And prepare them for that. And because if I've heard it said many times that if you tell a patient about it before it happens, it's a discussion, and if you explain it after it happens, it's an excuse.
Yeah.
In the patient's mind.
Yes.
So yeah, always better to have those discussions up front. That they're going to have fewer. You're going to have fewer teeth if you're going to have an implant supported fixed situation.
Okay.
Great. So let's see. So from there, we can make our implant stent. We can duplicate the denture. We can place our markers. Things are a lot different now with the advent of digital treatment planning. But this is kind of the classic way that I've done it is we look at the complete denture, whether it's so if it's going to be a direct to implant, then sometimes we can't do an aesthetic try-in, but if they've been a denture wearer for a while and their old dentures don't fit, or if they're worn out, we may not have to make the new denture, but we certainly have to make a denture setup, and it has to be approved by the patient, and it has to be functionally correct for what our goals are going to be. So so we may just make the denture diagnostic setup and then use that as our template. So this is the my old school way of doing it, and still often a surgeon will ask for this even if they are doing a digital implant treatment planning, because at the time of implant placement, you might want to confirm with a clear duplicate of the setup. So back in the day, we used to place the little ball bearings when we were using radiographs. For CT, we'll use other markers that'll show up on a scan. If it's an analog placement, we'll have guide holes for the implant drill, or if the goal is to have an overdenture, we might just have an open area with the like an open lingual window, so that we can see where we want the teeth, the denture teeth, to be. So for guided surgery, still can't do it without a properly set denture setup, whether it's analog or virtual. So this is an example of a patient who had failing implant and tooth supported FPDs. So she was all crown and bridge on implants, but everything was by the time she got to me, things were falling apart. And this was this is an unfortunate. These are the kind of unfortunate situations I often see as a prosthodontist of things that just didn't go as planned, or maybe they got a few years of mileage out of it, but someone who has continuing advancing periodontal disease, occlusal overload, bruxism. The bruxers can just destroy anything that's put in their mouth, and that's what this lady did. So we disassembled everything, and the surgeon took out all the implants that had failed, and this is what we were left with in this situation. Very unfortunate. Luckily she her expectations were not super high at this stage of her life, but we placed immediate dentures. And we thought, okay, well, she doesn't want to attempt implant treatment again, after, no matter how much we encouraged it. So I said, well, if, we can try to make use of the implants you have left, but we're making conventional dentures, and, these implants can maybe assist. And seemed, so we thought we'd get, maybe a little bit of time out of these. One of them so this is one way to remove the last implant. And but again, luckily this patient was informed that this is probably, we don't know what's going to happen with these implants. We'll try to get some use out of them, but it's pretty obvious why, this one failed. It had already had advanced bone loss, and just put a little bit of torquing force on it, and out it goes. However, again, she was okay with wearing dentures, and we were able to create something aesthetic for her. So basically, just to summarize, the complete denture, it can not only be an effective first phase of implant treatment, and can help with patient management, can help with us achieve better aesthetic and functional results in the implant phase. And the complete denture is an important implant treatment planning tool. Helps us establish our aesthetic and functional goals. It helps us communicate better with our surgeon. That's my daughter, Chloe, taking over Disneyland. So,
pre-pandemic.
Yes, back soon.
Yeah.
Questions, comments, tomatoes to throw?
Well,
Is your daughter going to be a dentist?
No, but the one you saw is working part-time in my office, though. So I put her to work. She wanted to take a pandemic break from school. So I suggested that she get some real life experience during that break.
that's one of the best moments. Go ahead. Let's see who has any questions.
I do. I have a
Yes.
question, and it's about the educational process. Are you seeing young people come into your specialty, or are you seeing more of the seasoned, specialists staying with it more so? What's the next generation coming forward in this?
In prosthodontics, you
Yes.
mean? Well, typically the prosthodontic residency is 3 years after dental school. So yeah, most new prosthodontists coming out are go usually directly from dental school, or maybe they'll do a hospital. I did a 1-year hospital internship before going into my specialty. So I had one co-resident who had been a general dentist for 10 years and decided to go back to school and specialize, but that's a little less common.
Did you find that one that went back to school to pick up the pace faster than the less experienced ones?
Yeah, I mean, he had a lot of good real world experience, but then again, he had also, had to unlearn some bad habits that he picked up over the years as well.
Sure, right. I mean, it's just like, a lot of times going into an MBA program, they want you to work for 3 or 4 years, get some real world experience, and then come back and we can show you what you can do by expanding your educational base.
Sure.
Can you talk a little bit about your care with cancer patients, and the specialty of that and the dynamic of that?
Oh, well, that's a whole another series of talks, but part of what I do is, as a in dental oncology and maxillofacial prosthetics, we work with the special dental problems that that cancer patients experience, and specifically, the worst issues are in patients who have had cancers of the head and neck, where maybe they've lost some of their oral structures, maybe they've lost part of their maxilla, and they need a obturator, a specialized prosthesis so they can eat and speak properly. Often patients right now, HPV is a huge cause of some of the oral pharyngeal cancers, tonsillar cancers, base of tongue. So these aren't people who are necessarily going to have big surgeries, but they're going to have radiation and chemo, and we have to protect the remaining teeth and be preemptive, because they if a patient has a advanced periodontal disease in a tooth, and they've had high dose radiation in that arch, Alfred knows very well that it could be very dangerous to extract or do a periodontal surgery in a patient like that. So we have to work as a team. So basically, we're part of the medical team when we're working with head and neck cancer patients, and so it's a very interesting kind of subspecialty part of what I do.
And you're very unique in this, that you have subspecialized in it, and a few have. So your presence in our community is greatly appreciated. Instead of sending someone to UCLA, which a great academic environment, they could be in a private practice being taken care of by you. So that's definitely a support, as well as you know, you're our source of support for the specialty. We reach out to you when we have such patients in our practices to get resources from you or guidance. Anyone has any question?
I do have a question about hygiene. I've only experienced one patient who has an all-on-4. And how often should they come in to have that cleaned? And what's a recommended procedure for thoroughly cleaning the all-on-4 when the implant's not out? It's in the mouth, the denture's in the mouth. So can they use a water pick? I mean, what basically can they do to keep it as clean as possible?
A lot of things. So as far as interval, a lot of it depends on patient factors. If they're doing a tremendously good job at home and they're coming in with very little plaque, which is kind of the exception rather than the rule, as we all know, then we'll make it maybe a 6-month interval. Most of my implant patients in that situation should see, I recommend every 3 months for anyone who's having, a lot of difficulty with manual dexterity, difficulty keeping things clean. So it's individual, it's per the patient, for the patient's needs. Using the, the plastic scalers for the most part around the abutments, usually gets the job done. The ultrasonic, which we're using less of, hopefully we'll be getting back into using the Cavitron more soon, because the Cavitron with the implant tip really helps a lot flushing out the plaque from these prostheses. Also the design, we have to make sure that so before even the hygiene starts, that prosthesis should be designed to allow good hygiene access. Most of the for home care, I'll recommend the water pick on a low setting. Superfloss, it's often hard to get the patients to use the superfloss, but it really is the best thing. So I spend a lot, if it's a hygiene visit, we'll spend a lot of time using the superfloss, and making sure that that the abutments are clean. And and avoiding abrasive toothpaste if there's a if it's a a denture tooth and an acrylic on a titanium bar. We don't want to use anything too abrasive on the acrylic portion of it. And so it's really, so the real answer is it depends on each situation. I will usually, if the patient persistently has problems keeping things clean, then we might want to unscrew the prosthesis and clean it ultrasonically in the lab, and get access to the abutments. I'll usually try to avoid that because every time we remove it, you can pretty much torque the screws maybe 3 times max before you have to replace them. That gets a little more expensive for the patient, and it's very time consuming. So if you're going to be removing prosthesis and changing the screws, the patient has to be aware ahead of time, not after the fact, that that's going to be an additional maintenance expense.
Thank you. I have one more question. As far as the water pick goes, do you ever recommend some peroxide or some bleach with the water pick solution? I mean, I totally believe in it, but how do you feel about it?
Yeah, I'm fine as long as it's what are they deleting, like 10-to-1, something like that?
Yeah,
Yeah.
like a squirt of peroxide or a capful of bleach
Yeah.
in the water pick.
1 teaspoon.
Yeah,
per-
I'd
I
probably.
find it highly effective, but I don't know about the bleach. I mean,
I
know it's
haven't used it.
recommended.
Haven't used it personally. Alfred, any thoughts on that?
I have a patient that stays a lot, so I don't recommend it for every patient. But this one, we have recommended him to start using some bleach in the water container. It's a couple of drops in the whole big bucket of. I tend to say lukewarm water, not very cold, not very hot. Just to support what Ron was saying, preparation of the patient is very important. Treatment planning, the teamwork, and preparing the patient, explaining what they should anticipate with some of the challenges, some of the complications, especially hygiene. Design is very important. The design goes part of that preparation. That is what comes with the mounting, with the denture preparation, with the surgical guide preparation, surgical reduction preparation. All that leads to the final good design. It's a lot of work that goes into it as a team, and using the right lab. Not only lab can perform and provide us the best quality. I completely agree with Ron that the follow-up is important. Ron, I tend to say the only way to know how good they're doing, especially maxillary all-on-4, is take it out at least the first 6 months after their best effort and see what's underneath. And then you get the guy a sense of what's coming. Some are very good, some aren't, but ultimately there's going to be access challenges, and the best approach is x-rays to see what the level of bone is. Any changes in the bone level gives you a sign that there could be a problem. So
X-rays annually.
Yeah. Now back to you, Ron. When they come back for their follow-up at your office, once every 6 months or so, how often do they come in?
So it's typically 3 to 6 months, depending on what kind of hygiene they're performing at home. So we have some patients who come in and there's just so much plaque, it's outrageous. Even though there's great hygiene access, they're just not doing it. So I make sure, as you know, in the maxilla, I always make sure that we have either flat or convex, so that there's definitely access everywhere for hygiene. In the mandible, we create even more room because we're not worried about interfering with speech. So yeah, if they're coming in with lots of plaque on there, then we'll make it more of a 3-month interval.
And Linda, emphasis is the design. As Dr. Koslowski is mentioning, because if there's undercuts, then the plaque is trapped and no one can access it. So the design of the prosthesis is important, which is also goes down to the surgical part, because surgery is dependent on the design as well.
Okay, thank you.
Can I
This-
add something? Dr. P, can I add
Yeah.
something?
Go ahead,
It's-
Mary.
The USC did the study. It was Schlotz, Jorgen Schlotz, that for the bleach, and it's 1 teaspoon for the 300 milliliters of water. We start our patients out with half a teaspoon because you don't want to start them out at too much. But that's basically what we tell them: a half a teaspoon 3 times a week when we put the bleach in the water pick, if we're recommending it. And then the other thing that was recommended too, Linda, if you're interested, I don't know if you were here, we had one night a lady talking from Florida, remember Dr. P, that was talking about oral hygiene and the hygiene. And she said another thing, and I haven't had a patient yet to try this on, somebody that's in this situation, but Dr. Koslowski, since you have a little more of those patients, she's recommended the Oral-B, the pointed toothbrush that they have to go interdentally, that you can actually she was showing us how to come in from the top with that to clean underneath. Might that I haven't had a chance to see a patient with one to even play around with that yet, but
and also
Sounds interesting.
this is through Strumman. It was a water-dick tip that was like a hook.
Oh, yes, I've seen that.
yeah, but
And
electric toothbrush, Dr. P, it was the one that's shaped like an end tuft. She said
yes,
you can
that
down-
one too, right. It was a good presentation.
With
Yeah, I
curious-
remember.
yeah. I mean, I just
Right.
we patients in that I've seen be able to play around with that.
Now, any question? I know Susan does some of this. Susan, with experience, you have any questions or experience to share?
No, but I will just say that a lot of these people who get those all on fours, they just make the assumption that, wow, these are my teeth and they're going to be great. And it's important that we educate them and say, you need to come in regularly. You need to take care of this. If you grind your teeth, you need to wear, I mean, Ron, you made a great remark when you said, if they grind their teeth like crazy, no matter what you put in your mouth, they're going to shred it anyway. I have a patient in my practice who has a full upper of implant supported porcelain to gold crowns and a lower all-on-4 denture. And we're swapping out the teeth on that lower for the 3rd time in like 12 years. And there's been just so much in and out on that. We lost one of the threads on one of the bar. It's worn out. It's been in and out so many times. And, she had a meltdown about that. And, well, can't you just like cut the bar and put something in there? And I go, no. And it just went on. And I go, maybe you need to get another opinion, but I didn't send her to you.
Thank you.
But yeah, these people are, can be very difficult. And, why are my teeth wearing down so fast? And I go, because I'll ask her to tap together and it's like a bear trap closing. Unbelievable. I go, try to do this really slow. The fact that she left me doesn't bother me after.
We all face situations like that. I have one patient who's constantly breaking teeth off his hybrid because we didn't know he was a bruxer until we put him in something solid. He first came in with end stage perio, so couldn't generate any force, and then we gave him the ability to chew, and chew he did.
Well, these cases are difficult also in that, I have one right now where the patient has all of or most of her upper teeth with crowns, but she a drug problem. And when so Dr. Hale put in the implants, and we put in a very small temporary denture, which she grinds like crazy because she's on antidepressants too. And all the implants lost. Had to come out, wait 6 months, start over again, put the implants back in, no loading. But I mean, this woman's been without any teeth for like a year. And I mean, it's so hard to develop a centric relationship because there's no muscle memory at all. Yeah. I mean, it seems so simple when people are dentated and they have teeth and you tell them to close together. And then when I kind of learned this when I was teaching full dentures at the free clinic in Pacoima with UCLA students. And we get people in who hadn't had one arch or the other for years and years. And you tell them to close together and they'd be all over the place. And the kids would come and get me and they go, what's the matter with these people? They can't close together. And I go, there's no muscle memory. They have no sense of where their occlusion is. It's very
Susan, you made a very beautiful point. Either no teeth or partial, and Ron was saying it too, when they go into a new set of teeth, all these muscles, every function is different. And you have to watch these people very carefully, adjust their bites constantly because they're adapting to this new environment.
Yeah, I mean, this woman I'm talking about, she's on her third temporary denture just because she was so overclosed and we couldn't just open her up all of a sudden. So and she goes, what's taking so long? And I go, you're a difficult case. And I said, I can't just construct something for you that puts you at a correct vertical height and just go from 0 to 100. I said, we have to work toward this. So they're very interesting cases.
Go ahead, Ron.
Great situation for 0-degree teeth.
Yeah. Oh, okay.
A flat, yeah.
Just
some may not know. All right. Let's Ron, now your any other questions? If not, then we can go to your second part.
Okay. We've got, is everyone still awake? Should we, I have another topic if everyone's interested in on time management. And it's a very kind of a radical approach to it that I wish I had enough discipline to practice more, but it's kind of an ideal. So let's go ahead. Get back to okay. So let's get back to screen sharing. And am I screen sharing still or no?
Not yet.
Okay, let me get back to that.
There you go. Now it's you're sharing.
Good. Let me get back. Okay. Yeah, this was a store in Manhattan. I don't know if they're there anymore. Okay, so this topic will probably generate a little controversy also. This is a summary of time management techniques used by one of my business mentors, Dan Kennedy, and but just to give a little more background, that in recent years I'm looking more at working, not more, but in addition to working in the practice, working on the practice. Michael Gerber talked about this in his book, the E-Myth, which is the entrepreneurial myth, where it's kind of as professionals, we in school we learned how to take care of people. We did not necessarily learn how to run a business, and as experts in our craft, our feeling, and certainly my feeling was for many years, that should be enough. And if you're really good at what you do, then yeah, your practice is going to be successful. And a lot of us got a little bit of a rude awakening going into practice that you've got to work hard, not only on your clinical skills, but also in taking care of a practice and making sure that it survives so that you can take care of your people. This is not what they taught us in dental school. It was definitely not what I was taught as a resident. So going down the entrepreneurial rabbit hole, there's a lot of interesting books to read. One of them that I would recommend to anyone is Think and Grow Rich, written by Napoleon Hill back in 1937. And then some of what we're going to talk about is some of Dan Kennedy's work as well. Other inspirational people, Jim Rohn had some important things to say about time. He said, days are expensive, and when you spend a day, you have one less day to spend, so make sure you spend each one wisely. He also suggested don't join an easy crowd, you won't grow. Go where the expectations and the demands to perform are high. That's why I'm here now. That's why I'm studying with Dr. P in the SPEAR study group, and so again ties back into the never-ending improvement. One of Jim Rohn's most famous students was Tony Robbins. He said that once you've mastered time, you'll understand how true it is that most people overestimate what they can accomplish in a year and underestimate what they can achieve in a decade. Dan Kennedy is also known as the professor of harsh reality. He's written many books, all prefaced by his trademark, no BS. So time management for entrepreneurs. One of the things that he talks about is the fallacy of what you need to generate in an hour in order to have we talk about sometimes the $1 million practice. So a lot of practice management gurus will tell you, okay, well, if you want to gross $1 million, working 50 weeks a year, 4 days a week, 8 hours a day, you just simply do the math, and you need to produce $625 an hour, and and there you go. So what is not really discussed is that at least I know in my practice, I don't always have 8 hours of productive time a day. I'd say, if we're lucky, maybe 33% of those work hours are truly productive from a business standpoint. So if we multiply that $625 times 3, then we're looking at more of $1,875 an hour needed to gross that $1 million. So Dan talks about things that take us away from our focus. He calls them time vampires, and he doesn't pull any punches. He calls them needy, thirsty, selfish, vicious creatures who will suck up all your time and energy. And he says that there's a stake in the heart for each one of these time vampires. So we'll have a little fun and see if you know any of these people. There's Mr. Have You Got a Minute? They're always in your doorway, or sending multiple emails and texts. And the stake in the heart for that is to say something. Well, I'm busy right now. Let's meet at 4 p.m. for 15 minutes and tackle everything on your list at one time. There's Mr. Trivia, who can't or doesn't want to differentiate between important and unimportant, major and minor. So the solution that he suggests for that is to interrupt the interrupter. Just say, I'm very busy. I'm only dealing with 9s and 10s on a 1 to 10 point scale. Everything else must wait till tomorrow. Is this a 9 or a 10? There's the soap opera star. They'll turn everything into an emotional crisis, react to everything, magnify everything, try to pull you into their drama. So the stake in the heart. Well, Dan goes as far as saying, well, you don't want those people. I'm not that extreme because everyone's, with the past year that we've all experienced, there's a lot of drama. So, however, if you have to, excuse me, if you need to get back to your focus, well, you can just cut to the core of the problem and tell them what to do. But that, so that will drive a drama-driven person away because they're not necessarily looking for solutions. They just want the drama to continue. Or you can just tell a long, boring, pointless story until they're so bored they go away. Avoiding interruptions. These are all things that are suggestions for not being interrupted. One of them is to be inaccessible and have, we've heard for years and years about how we should have an open door policy. Well, if you really don't want to be interrupted, you can't, that's not compatible with the open door policy. So maybe have a closed door policy. Don't answer the phone. At home, you don't have to answer the phone. I'm not even sure why I have a landline anymore. And at work, hard thing to do, but lock up your cell phone. Get a grip. This is probably one of the worst things for all of us. The emails, the texts, not so many faxes anymore, thankfully, but usually the faxes that come through are the ones we specifically request. But emails and texts, a lot of people expect immediate responses. Train them that, the way that you want to be communicated with. Interesting thing about Dan Kennedy is if you want to work with him, you've got to fax him. He doesn't have a phone number published or an email. So the idea is you decide what your terms are, how you want to be communicated with, and then let people know that. Establishing a firm end time for phone calls and in-person meetings, and conversations tend to stretch to fill whatever time is available. Be busy and be obviously busy. If it's obvious you're busy, the time vampires will not necessarily try to distract you. Punctuality. Dan calls punctuality the most powerful personal discipline in all the world. Being punctual gives you the leverage to expect and demand what others that others treat your time with respect. And again, Dan, being very extreme, doesn't even trust people who don't show up on time and won't do business with them. Wouldn't that be nice if we could do that with our practice, with our patients? Self-discipline, so regimen, ritual, commitment. 3 steps to success are in order. So don't react right away. So be aware of what the problems and opportunities are. Make a decision and then take the action based on that. Some of the top time management techniques that Dan discusses, One is linking time to money. Think of, time is money is taken literally. Be a bona fide expert in your field, which we all are here. Improve your reading skills, get the information you really want and need, select the things that you want to read for later. There are, you can use Google Alerts to alert you to things that you specifically want to know about. And for your TV shows, you can do on demand, so don't set your schedule around when a broadcast is. You can use drive time as learning time, so we can listen to podcasts while driving instead of listening to talk radio. And so this is a big problem for all of us now as well, the information avalanche. Things are coming at us from all directions. So specialize, but don't be myopic. So great ideas can come from outside sources. Oh, we just lost our, here we go. Okay, organize and capture your ideas. So Disney uses storyboarding. You can use a voice recorder. You can have notebooks and pads laying around. So whenever you have an idea, you can jot it down. Here's the ideal for all of us, is to fire ourselves, and but we can start by delegating, and so this is something that I'm still struggling with, and I'm sure a lot of us are, is that there are certain things that we should not be doing, that we should be handing off to others in our team. So in order to do that, requires self-analysis, self-understanding. What do I do best? What do I do well? What do I not do very well? Delegate what you don't need to do. Don't do the $10 an hour jobs, or even the $100 an hour jobs. So if I'm running to Costco to pick up stuff for the office, I'm doing a $10 an hour job. If I'm doing, as much as I love it, if I'm doing some of my own lab work and kind of hiding in the lab and doing, getting absorbed in that stuff, even though I enjoy it, I'm still not doing what I'm most what I'm best at. And then for those of us who have associates in our practices, that's kind of the ultimate way to fire yourself. So Napoleon Hill, I mentioned earlier, in 1937, he was set on a task by Andrew Carnegie to interview as many successful businessmen as he could. He was a journalist by trade, and he took this upon himself. He took on this task, and he found out that common attributes in successful people are a burning desire to succeed, having a deep faith, having specialized knowledge, good imagination, organized planning, and persistence. He also talked about the power of the mastermind. So the mastermind is a group of people who not only learn together but help each other. So it's an organized process for heightened productivity and accelerated accomplishment. So Hill saw that that people like Carnegie, Ford, Firestone, and Edison, and others, they all met together regularly in order to basically put their mental power together, and their thinking power would expand exponentially. and not to mention that at the time they could do some insider training too, but but really the gist of it is that they could share their knowledge, help each other with their struggles and problems. So Hill described this as spontaneous explosions of breakthrough thought that occur from the energy in the room and the combined focus on a single problem, opportunity, or question. So other things, buying time, buying expertise. Oh, sorry about that. Choosing false bargains can prevent successful accomplishment. Investing in coaching. Highly successful people in all aspects of life. In sports, you don't see any successful athletes who don't have a coach who they've hired. So they can help produce a quantum leap up and accelerate the speed of achievement. One of my coaches is Jay Geyer at Scheduling Institute, and he's also a harsh reality guy. He's actually one of Dan Kennedy's most successful students. One of his favorite sayings is, "You get what you deserve," and you can only have one focus in life, main focus in life, what you're happy about or what you're unhappy about or what you're grateful for. So you can't have unhappiness and gratitude occupying the same space in your mind. So make a choice. Talks about the two economy system. So this is especially a hard thing to do in 2020. It took a lot of work to maintain this. This model also comes from Stephen Covey from the 7 Habits of Highly Effective People, which that was one of the pandemic activities that I did with my staff when we couldn't work last year. We had a little book club and met regularly to discuss some personal development principles. So that's where this comes from, where there's an outer circle of things that we have no control over. What the government does, what taxes are going to be, what are they yelling about on talk radio. So Jay suggests just shutting all that stuff out of your mind as much as possible, especially when you're at work, and the inner bubble, as he calls it, is your own, what you do have control over, your own thinking, your own business. What are your habits? What kind of team are you building? And what are you investing in? And also your family time. What are you doing with your family? How are you you're spending your quality time with them? Other interesting things to look into. Maxwell Maltz wrote a long time ago, wrote a book called Cybernetics, which is a way to create a certain state of mind that best facilitates achieving peak productivity and directing 100% of your mental power to one matter at a time. This concept of psycho-cybernetics is to deliberately make your subconscious work as a finder, organizer, and provider of information. This is a tough read. I think I'm on my 3rd go around trying to absorb this one, but it's basically all about training your subconscious to improve your effectiveness. So if another year passes and there's been no meaningful progress, well, you've got to evaluate why. For some people, it's entitlement thinking. For some people, they get something out of whining and complaining and making excuses. And at the same time, successful people are taking massive action. So back to what Dan recommends. He calls the information overload. He calls it crap overload. And so keep the games and entertainment at home. Do your shopping on evenings and weekends. And avoiding interruptions. So a 4-second interruption, so the US Naval Research Laboratory found 4-second interruption triples the chance of a mistake when returning to the same task. Surgeons made mistakes during a simulated gallbladder surgery 44% of the time with forced interruptions and 6% with no interruptions. And so there's time management. Medicine, unplug when at work. Lock away our electronic devices. You can even, if you need to have a cell phone out, just have a phone that doesn't do anything else. Have a dumb phone. Blocking time. You can, we all are working on blocking our patient schedule just right, but we can also block our appointments with, outside of work. We can block out appointment time with ourselves for specific tasks and set starting and ending times. Schedule that play time and know how much time you're going on, online. So set a start and end time for your YouTube and entertainment time. Have a success environment, safeguarded isolation for productive time. Have the needed materials and resources at hand and control the distractions. I think we're good at that when we're with our patients, and then at least for me, it kind of slips when we're not. So separate the useful information from everything else, and stiffen your spine. So again, this is back to Dan's harsh reality. Dictate how you want to be communicated with. Don't tolerate people who refuse to honor that. And don't follow the crowd. Oh, and how to do that. So if you have a marketing system that brings in more business than you need, then yes, you can fire troublesome patients. Don't follow the crowd. Opt out of what everybody is indulging in and addicted to. Facebook, Twitter, Instagram. Perry Marshall talks about the reboot. Suggests unsubscribing from email lists that are not delivering tremendous value. Delete social apps from your phone. Average American is on Facebook 5 hours a day, believe it or not. Don't start your day on a device. Good reminder for me. I have my phone next to me and a book next to me, and it is so hard to not grab the phone first thing in the morning. Start the day with gratitude, journaling, to-do lists, decide what to delegate for the day. And when there's work to be done, do the work. So Timothy Ferriss back in 2007 had a huge bestseller called The 4-Hour Work Week. And, and it really was more of an attention getting thing. So there's no such thing as a 4-hour work week. There's no such thing as a 4-hour work day, really. And, Jim Rohn's principle of massive action is really what counts. And, we'll see people who are just doing tremendously well, and we'll see, Dr. P is actually one of my inspirations, because he's, look at everything he's doing. He's through the whole pandemic. He's doing this, the dental hour, and he's done it without fail. And then all these different platforms communicating on email and regular mail, texts. So, so look at everything that he's doing. Joan Rivers, if you haven't seen it, I would highly recommend going onto, if it's still on Netflix. She had there was a documentary before she passed away. They made a documentary called A Piece of Work. and the drive that she had, being productive mattered more than anything. And you watch this documentary, and she is just so driven, and to write jokes. She has file cabinets full of jokes, and just and always wanted to be better, and was always very grateful and generous. You might remember Admiral James Stockdale. He was Ross Perot's running mate way back when, if anyone's old enough to remember that. But another thing that he was very well known for is that he was a POW in Vietnam for 7 years. He was the highest ranking naval POW in Vietnam, and he survived. He created a code of conduct for prisoners, which governed torture. Jim Collins talks about the Stockdale paradox in his book Good to Great. So they asked Stockdale, how did you get through 7 years as a POW and not give up hope when others around you were dying? And so what he said is it's kind of a type of optimism, but not a sunny kind of optimism. And I think this applies to the whole pandemic ordeal we all went through this past year. Is you must never confuse faith that you will prevail in the end, which you can never afford to lose, with the discipline to confront the most brutal facts of your current reality, whatever they may be. And so that is how he said he made it through. So what are the things that I do in my practice? We like to give our patients a shock and awe welcome. We want to show up like nobody else. We have a new patient experience. We like to recognize and thank our referral partners. Newsletters can be emailed or printed and mailed. They can be sent to patients. They can be sent to doctors. And we can always begin with the end in mind. So these are my reasons why. Back to Disney, back to Chloe on the left, Madison on the right. Those are my gals, and they're why I do what I do.
Ron, final.
Thank you.
To summarize what you shared today, is not only we have to work on ourselves, we also have to work on our patients, get to know them, do what we can do to the best we can for the patient themselves, but to get to know them is very central. And as Sarah was also saying, the tour of the mouth, the tour of the body, getting to know their personality, as you're saying, personalities are important. All of that is what brings everything together for us to enjoy what we do every day. And he just shared some of it with us tonight, and I appreciate so much. Any last thing you would like to share with the team?
Great presentation. Thank you very much.
Thank you. I really appreciate the opportunity to learn with all of you, and it's just been great. And a happy National Prosthodontics Awareness Week, which I'm sure is on all of your calendars.
It is on our calendar, and we're thankful to have you with us in our neighborhood, in our community. You're the best.